come for a review goes into atrial fibrillation. However, he is what? Hemodynamically stable. That means his blood pressures are right, the heart rate are okay. Okay. He also declines any attempts to cardiovert him into sinus breathing. He doesn't want anyone to cardiovert him. He's like, I don't want that shock. Recommend appropriate treatment for kidney. What are you going to do for him? Okay. So as we go through this presentation, I want you to be thinking about this, kidney and his problems and how he was managed or how you're going to manage him. Because at the end of it all, we're going to crown up with this. Okay. So heart failure. Heart failure can mean symptoms or signs caused by structural or functional cardiac abnormalities. Okay, at least and at least one of the of the below. Okay, so your patient will either have a structural problem on the heart, either the heart is too big, or there's a valve problem, or there is an infarct somewhere. You get, so there's a structural problem somewhere on the heart, like the anatomy of the heart has been compromised, or the patient actually has poor function. The heart is not performing well. The ejection fraction is poor. Cardiac output is poor. Stroke volume is poor. Get it? Or maybe end diastolic volume is poor. That is what function refers to. So one of those two, either structural derangement or functional derangement. And then the patient will either have elevated natriuretic peptides. These peptides indicate to you, this is a protein that indicates to you that the patient's heart is undergoing some degree of strain. Okay? Some structural strain is not affecting the heart, giving us an elevated BNP. We call this BNP, beta natriuretic peptides. Or the patient will have objective evidence of cardiogenic, pulmonary, or systemic congestion. They'll generally have fluid overload. That's what we mean by fluid overload. This patient will be congested, either in the lungs or in the extremities. Okay. There's some risk factors or causes of heart failure. The number one cause of heart failure is hypertension in our setting. There are so many hypertensive patients. We discussed hypertension last time with Dr. Carol. Hypertension is the biggest problem in Uganda in terms of NCDs. It's the number one problem. I always tell everyone I meet, I always tell my students, I always tell my interns, everyone must know how to manage hypertension because hypertension is the number one problem of all cardiac diseases. Okay? So you cannot say you're a pharmacist and you don't know how to manage hypertension. You can't say you're a nurse, you can't say you're an MO, you can't say you don't know how to manage hypertension because it is the number one problem in cardiovascular disease. It's the HIV of the heart. Okay, it's like the HIV of the heart. You need to know how to manage hypertension because it causes almost all cardiovascular complications. We can also have hyperthyroidism causing heart failure, arrhythmias, infections like HIV and TB can also cause heart failure. Drugs, especially like anti-cancers, can cause heart failure. Chronic lung diseases like COPD, asthma, can later result into heart failure. Anemia can cause heart failure. Okay, so what do the cardiologists look at when they come into a diagnosis of heart failure? There's something we call the Framingham HF or heart failure diagnostic criteria. It has major criteria and minor criteria. So the patient must have at least two major criteria, or they will have at least one uh, major criterion plus two minor criteria. Okay, so what are the major criteria? Orthopnea. Okay, orthopnea. Orthopnea simply means the patient can't lie flat. This guy tries to lie flat and it's difficult. He gets difficulty in breathing when he goes flat. When he changes position, basically, he goes flat and finds it very hard to breathe. Jugular when the cardiac output is poor, ejection fraction is poor, and when you're having right-sided failure, you're going to have jugular venous distension. Hepatojugular reflux. This also tends to happen, especially with right-sided failure. The patient with ascites, blood accumulating in the what we call splanchnic circulation, in the liver, in the to the jugular, circulation. Those will be very distended. Patient will have crackles. Crackles were previously called drills. Diseases don't read books. Okay? So your patient has heart failure with preserved ejection fraction, and they have come with what we call atrial fibrillation. This is the commonest arrhythmia world over. The commonest arrhythmia is atrial fibrillation. There are even patients who are walking on the street with this arrhythmia. Okay? So when your patient has heart failure with preserved ejection fraction and they have atrial fibrillation, what are we going to do? We can do what we call rate or rhythm control. We control that patient's rate. So atrial fibrillation basically means the patient has very fast rates or abnormal. The rates tend to be fast and they are and 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 generally they're having many SANs. I would say abnormal SANs. Okay, in the we know what we call a SAN. Sinoatrial node is supposed to produce impulses and then send them down the fiber all the way to cause the contractility. But for this patient, it's a bit different. There are very many SANs doing that. So they will end up having a heart rate that is abnormal, tends to be higher. The cardiologist is able to make that diagnosis. Okay, they will tell you on the ECG, there are no P waves, and then all that detail, which you don't necessarily need to know the pharmacist. Okay, what's important for you is to know means like this, like that. And we have said there's what we call rate control and rhythm control. There are drugs that can reduce the heart rate of your patient. Beta blockers. Okay, they reduce heart rate. We know that from our year to pharmacology. Beta blockers can reduce heart rate of the patient. They are what we call non-dihydropyridines. They can also reduce heart rate of this patient. These are non-hydropyridine calcium channel blockers can reduce heart rate. The problem with these two drugs, the CCBs and the beta blockers, the problem is they can also reduce blood pressure. Are you seeing that? So non-dihydropyridine calcium channel blockers like dihydropyridine, diltiazem and verapamil can reduce blood pressure. Beta blockers like metoprolol, avendilol, and bisoprolol, yes, to some extent, it's not the same extent they will reduce blood pressure. Digoxin can also be used for this patient when they have atrial fibrillation. The advantage will not reduce blood pressure, but it can reduce heart rate, and we give it to reduce the heart rate in atrial fibrillation. Digoxin has since fallen out of favor in cardiac facilities. However, it's very beneficial when it comes to atrial fibrillation. It's the number one indication for digoxin. Okay, atrial fibrillation. And patients who have atrial fibrillation will also be given anticoagulation. And those of you who have been to cardiac facilities know about the Chad's VAS score. You read about that. I won't go into that. Based on the Chad's VAS score, you're going to do what? You're going to start.
Excuse me, doctor.
Yes,
The slides are not showing.
you cannot see the.
They are showing now. Thank you.
Can you see the slide now?
No, they had yeah.
Okay. So based on the Chad's VAS score, you will start anticoagulation. Now, your patient might have heart failure and also hypertension. Okay? The blood pressure, uh, you will find that the patient has elevated BPs. There are drugs that can reduce blood pressure. You can use angiotensin receptor blockers in combination with neprilysin inhibitors. That is what we call ANI, ARNI. An example is valsartan in combination with sacubitril, the brand name Chacoplast. Okay? We can also use ARBs, plain ARBs, valsartan, candesartan, can reduce blood pressure for this patient. We can also use MRAs and other diuretics. Mineralocorticoid receptor antagonists, spironolactone, eplerenone, diuretic agents like furosemide can reduce BPs, and also thiazide-like diuretics like metolazone can be used for heart failure with ejection fraction and also hypertension. You have to look for secondary causes of hypertension. There are patients who will come with coronary artery disease. Okay, so we're talking about MIs, basically ischemia in the tissues of the heart. You need to, there are procedures that cardiologists can do. Okay, things like coronary angiograms and all that to do investigations and figure out exactly if this we are having atherosclerosis, giving us a clot in the coronary artery, and then all that detail. Or if this problem is not necessarily caused by atherosclerosis, or it's caused by inflammation, or it's caused by
I think Dr. Silas has gone off. Let us first get a solution there.
Yes, good evening, dear colleagues. Should I think I'm the only one not listening to what is being, what is going on here, or we are all not listening? What could have gone wrong?
I'm trying to get in contact with the presenter, but seems to not to be picking. But please be a bit patient. The doctor is getting back in a few.
All right, apologies for dropping off. Um, are you able to see my slide?
Yes.
Okay, thank you for being patient. Uh, my I I didn't know that my data had run out, so I've just put some more. Um, Sorry about that. Let's pick up from. I don't know where I had stopped.
The previous slide, we're still talking about coronary artery disease.
Okay, we were talking about coronary artery disease. Um, so we had said that what will happen is the patient has heart failure with reserved ejection fraction, and they have coronary artery disease. There are some interventions that can be done by the cardiologist to be able to relieve this patient of that problem. Okay, we can also do things like coronary angiograms. We can do percutaneous intervention that is under coronary artery disease, and also we have medical management for coronary artery disease. Okay, which we will not talk about today. The patient also left with type 2 diabetes. Diabetes treatment of that patient as we want to target anyone below 7.5. And again, SGLT2 inhibitors are very important in this category of patients. Why? Because they have benefit in both heart failure and in diabetes. In fact, those drugs like dapagliflozin and empagliflozin were first approved for diabetes. Okay, but later on in 2023, it was discovered that these drugs had benefit in heart failure. Okay, by the Americans did a study and then clinical trials and then came up with that evidence and then they published it. We have a guideline actually 2023, uh, American College of Cardiology, heart failure with reserved out, and that's what we use. Even the Europeans adopted the same. They also have their guideline. We can use GLP-1 receptor antagonists in these patients. Examples include things like semaglutide and liraglutide. These drugs are very beneficial in reducing weight of the patient and reducing risk of atherosclerotic cardiovascular disease. So we can start this patient on such drug. However, we are saying that we have to avoid DPP-4 inhibitors like alogliptin and saxagliptin. Why? Because they are associated with heart failure. Okay, or manifestation of heart failure. If a patient already has heart failure, they will what we call they will exacerbate the manifestation of heart failure. Also, thiazolidines have been associated with fluid overload, so we do not use them in patients who have heart failure. Patients who have chronic kidney disease, also we can use SGLT2 inhibitors. We are seeing that these drugs have benefit in diabetes, in chronic kidney disease, and also in heart failure. Is not we try to avoid them in EGFR less than 30 due to the risk of hyperkalemia, due to the risk of acute kidney injury or worsening of we don't initiate them at that level, or we initiate them with caution. There is no absolute contraindication of these drugs, but there's a relative contraindication. In other words, you can use them with caution. If you're in an expert facility like Uganda Heart Institute, you can initiate the drugs, but monitor the patient's electrolytes and monitor the patient's kidney function. SGLT2 inhibitors below 20, EGFR below 20, still we can initiate them. However, we have to monitor the patient for side effects of this drug as well, okay, which we're going to look at. Patients can have obesity and they also have HFpEF. And patients who have obesity, we know the drugs to use. GLP-1 receptor antagonists like semaglutide and liraglutide, okay, can be used for these patients to reduce weight. And also, remember when you reduce weight, you're reducing the risk factors for you're taking away risk factor for very many cardiovascular diseases. However, we should take note of their side effects, okay, particularly pancreatic side effects. There are patients who have sleep apnea as a comorbidity, and obesity is one of the risk factors for sleep apnea. Okay, and Those patients need their weight to be reduced. Still, we can use the GLP-1 receptor antagonists. We can also recommend a sleep therapist for these people, okay, so that they can have the problem of sleep apnea dealt with. So this is heart failure with preserved ejection fraction together with comorbidities. And this is how the management changes based on which comorbidity. Okay. However, we have what we call heart failure with reduced ejection fraction. Heart failure with reduced ejection fraction is a bit different. We already know what it is. EGFR 40 and below. Okay. So we had said that heart failure with reduced ejection fraction is EGFR 40 and below. The management of heart failure with reduced ejection fraction is the same as the management of heart failure with mid-range ejection fraction, the same as management of heart failure with improved ejection fraction. So basically, these patients with mid-range ejection fraction and improved ejection fraction are managed the same way you would manage the patient with heart failure with reduced ejection fraction. The only unique one is heart failure with preserved ejection fraction, where we only use one drug, which has showed class 1 benefit, class 1 evidence, okay, that class 1 evidence that they have mortality benefit in heart failure with preserved ejection fraction. However, we are saying on top of this, we can add on other drugs when the patient has comorbidities. And you can see the drugs are listed in there. Okay. Now we have heart failure with reduced ejection fraction. This one we use four pillar drugs. They are going to tell you guideline directed medical therapy. Okay. Guideline directed medical therapy can be, will, or is a combination of these four drugs you see. Angiotensin receptor blocker in combination with neprilysin inhibitor, or what we call ANI, okay, like valsartan and sacubitril. Evidence-based beta blocker, BCM, bisoprolol, carvedilol, metoprolol, okay, evidence-based beta blocker. We don't just use any beta blocker in heart failure. We use those three, okay, bisoprolol, carvedilol, metoprolol, mineralocorticoid antagonists like spironolactone, eplerenone, okay, and then SGLT2 inhibitors come back. Are you seeing? And I was saying that these drugs, SGLT2 inhibitors, have become a miracle drug in heart failure. They can be used in heart failure patients across all ejection fractions, whether reduced ejection fraction or preserved ejection fraction. In preserved, they can be used alone. They have showed class 1 evidence that they have mortality benefit. They reduce the risk of the patient dying. And the goal of a health worker is to do what? To reduce the risk of death or to prevent the patient from dying. They prolong the patient's life. So SGLT2 inhibitors like dapagliflozin and empagliflozin prolong the patient's life in heart failure with preserved ejection fraction. These other drugs in HFpEF that you're seeing listed in this table, they might not prolong the patient's life in heart failure with preserved ejection fraction, but they will take away the symptoms. Are you seeing that? Remember that this drug reduces the risk of death. These other ones we are adding for comorbidities don't reduce the risk of death because of heart failure. Are you seeing? That is in preserved ejection fraction. In reduced ejection fraction, there are four drugs that reduce risk of death. There are four classes. Okay, I've talked about the ANI, I've talked about the beta blockers, I've talked about the mineralocorticoid antagonists, I've talked about the SGLT inhibitors. These four, we call them GDMT together, or we call them the pillar drugs of heart failure. There are four categories. These ones reduce risk of death. Okay. Treatment algorithm, we are treating what? Heart failure with reduced ejection fraction. Okay, patient comes in, like the one we have seen, there are drugs that we can keep adding on. If they have fluid overload and they come in, they're having edema, and what do? We titrate. We give the patient what? Diuretics, particularly loop diuretics. Are you seeing that? If this patient is having uh, they could be having symptoms, persistent symptoms, despite giving the patient what we call a guideline directed medical therapy. We can always add what? Hydralazine and azothiazide dinitrate. Okay. If this patient has a heart rate that is more than 70, okay, and they're already on a beta blocker, and they cannot tolerate a bigger dose, and they are in sinus rhythm, they're not having an arrhythmia, this patient can be given what we call ivabradine. It's a drug called ivabradine. And again, there's another drug called vericiguat. Okay? Patients are already on GDMT, guideline directed medical therapy, okay, but they keep coming back to the hospital all the time, all the time. We can give them vericiguat. Now, these drugs you're seeing listed here don't prolong the life of the patient, but they reduce the number of times the patient comes to the hospital. And they say these drugs have morbidity benefit. Okay, they reduce the number of times the patient will come to the hospital in a year. Okay, you don't want to keep seeing your patient in the hospital all the time, all the time. These drugs will do that for you. While these ones in this triangle, this is a triangle, whatever it is, will do what? Will prolong the life of the patient. So in other words, every chance you have to put these patients on these drugs, you initiate them. As long as they can tolerate them, you initiate those drugs. Then after initiating these drugs, then now you can start adding more of these. Okay? If they can't tolerate these drugs, then you can wait. But you put the ones they can tolerate. The doses are here. Isoprolol. We start with 1.25, then we make sure we titrate all the way to 10. Carvedilol, we start from 3.125 twice daily and titrate all the way to 25, as you can see there. Metoprolol, succinate. Now, metoprolol has two forms, tartrate and succinate. The one we use is succinate, okay, in heart failure with reduced ejection fraction. And you can see we start with 12.5, okay, to 25, then you go all the way up to 200 every day. Any angiotensin receptor blocker and a glycine inhibitor, like sacubitril and valsartan, sarcoplas, what we call sarcoplas, is what you're seeing here. Okay, we can set the dose at that. This is like 50 milligrams, a total of 50 milligrams. We can go all the way up to 200 BD. ACE inhibitors that have showed benefit in HFrEF, you can see them there. Captopril, very commonly used in pediatrics, okay, but also very commonly used in ICU settings. Critically ill patients, we tend to give them captopril to reduce afterload. Okay, then when they are more stable, we can now go to these other long-acting drugs. ARBs, we have candesartan, losartan, and valsartan. These have demonstrated benefit in heart failure with reduced ejection fraction. These drugs prolong the life of the patient. You can call them the Fantastic Four. Okay, maybe that will help you remember. The Fantastic Four include what? Include uh, beta blockers, include ANI stroke ACE inhibitors, stroke ARBs. Those are in the same category. ANI stroke ACE inhibitors, stroke ARBs. That is two. Then mineralocorticoid receptor antagonists. Okay. Okay. So we have MRAs, beta blockers, and then ANI stroke ACE inhibitors, stroke ARBs, then SGLT2 inhibitors. Okay. Those are the Fantastic Four, or GDMT, that have mortality benefit in heart failure with reduced ejection fraction. Now, these other drugs that I'm showing you here, these ones don't have mortality benefits, but they reduce the symptoms of the patient. As you can see them, the vasodilators like hydralazine, isonitrate. These ones reduce hospitalization, ivabradine, they reduce symptoms, vericiguat. Okay. Now, when you're adjusting, changing a patient has been on an ACE inhibitor, enalapril, and you're changing to ANI, you should allow a washout period. You should remember that. Okay, but also very important is the what you call dose equivalence. Okay, if the patient has been on more than 10 milligrams of enalapril for their heart failure, okay, and you would like to switch them to sarcoplas or to sacubitril and valsartan, we start from a dose of 100 milligrams, that is twice daily. And if they have been on an ARB like valsartan already, about 160 milligrams every day, we still can switch them to sarcoplas, this combination. So you can see when you if they've been on 160 milligrams of valsartan already, then you start from 100. This is 49 plus 51. That's 100 twice daily. So you need to know this equivalence because these are actual problems in the world. Okay, the team will be changing a patient from S inhibitor in Adapro to Sarcoplas, and you, as a pharmacist, are supposed to tell them that if the patient has been on 10 milligrams or more, then you need to switch them to this dose, to 100 milligrams of Sarcoplas BD. Okay, not okay. If your patient has never been on ANI, then we start from a very small dose. With a patient who is naive, okay, the novel initiation of ANI, or they are ANI naive, or they have never been on ANI before, or sarcoplas, then you start from a smaller dose. This is like 50 milligrams. 24 plus 26 is 50 milligrams. Okay, so then they begin to report. Those things are down there as you can see. Okay, you need to if they have a hepatic impairment, particularly child path score class B, okay, this is a liver injury of this class, then you start from, okay, that dose still. Elderly patients above 75, we also start from, because their BPs might be a bit soft. So, as and so does sacrability, okay? So you have to take note of that. So if the patient has been on an ACE inhibitor before, you have to assess that to initiate your ANI, valsartan and sacrability. Before you starting this, you allow 36 hours. Then you check this patient after 1 or 2 weeks to see how their blood pressure is performing. Are you seeing? Blood pressure, electrolytes, valsartan can increase potassium. You have to check electrolytes. And we have said that we have to take caution in EGFR less than 30. So kidney function is very important. BP is very important. The target dose must be what? If you do the math, plus 103 is 200 milligrams BD. This is the dose. We start down, like you can see here. This is 50 BD or 100 BD. The target should be to reach 200 BD. Are we together? So ACE inhibitors can also be given to these patients or ARBs. Okay? This is given to patients who can't afford ANI. ANI is a bit expensive. Those of you who have worked in pharmacies, for class is expensive. So there are patients who can afford it. So they will be what? On an ACE inhibitor or an ARB. Remember, we don't give both at the same time. We also don't do this together with what? With this at the same time. That's why we are saying this washout period. Are you seeing? We don't give those drugs together. They're in the same class. So inhibitor, we can give the patient captopril, enalapril, ramipril, lisinopril. Captopril, we don't normally give it to stable patients who are, outpatients, and why? Because we want a tracking drug that we can monitor. Drugs we can give ARB, we can give valsartan or candesartan, and still after 1 or 2 weeks, you have to optimize. You have to check the patient's. You have to keep checking patient blood pressures because these drugs reduce BP. Again, renal function is very important. Serum potassium is also very important. Okay, increase the doses, target doses. The goal is to initiate the patient on the drug and titrate it to the dose that demonstrated benefit in what? In clinical trials. Okay, and that's a gradual thing. It doesn't happen over 1 week. It happens over time. If you do it drastically, you're going to cause decompensation. The patient will crash. The BPs will crash. Heart rate will crash. Heart function will crash. So you do it gently, gently, gently until you reach the dose that guidelines have demonstrated to be beneficial. Mineralocorticoid receptor antagonists are also very, very helpful for our patients. Okay, with HFrEF. But the problem with them is increasing serum potassium. Okay, we have to always make sure we have serum potassium less than 5. Okay, because these drugs will increase serum potassium of the patient. Okay, renal function is also very important because patients who have kidney disease are prone to getting hyperkalemia if they are on this drug. So you have to keep checking the dose. SGLT inhibitors, the miracle drugs that we're talking about, dapagliflozin, empagliflozin, sotagliflozin, EGFR less than 25, uh, we are hesitant to introduce the drugs. Okay, uh, these patients will tend to get persistent what? Persistent UTIs. Why? Because these drugs lose a lot of glucose in the urine. These patients get euglycemic DKA, diabetic ketoacidosis, which is euglycemic, normal glucose levels. These patients will tend to get, they might get hypotensive. Okay, so we have to monitor these patients closely. Okay, those are the monitoring parameters. Sodium levels, you lose sodium, remember. Check when not in the urinating, you do urinalysis. Key to note is in the urinalysis, you're going to see glucose in the urine. It will be there. It doesn't mean your patient is diabetic. It's only a side effect of the drug. The drugs, these drugs in this class will cause your urine to have a lot of glucose. Your urine also have a lot of sodium. You will lose sodium. Okay. Then evidence-based beta blockers, BCM. Okay, bisoprolol, carvedilol, and metoprolol. Um, we keep on adjusting the dose, the target dose, monitor heart rate, monitor BP, and signs of congestion. Okay? Diuretics. Now here, these drugs starting from here, they don't have mortality benefit. These ones are for symptom relief. Okay, we give them to drain the patient of the fluid that is, causing them to be congested. Um, and then what's important is monitor blood pressure for this patient, monitor electrolytes, monitor kidney function. And when you're seeing you're reaching a daily dose of 160 milligrams, that is 80 milligrams BD of furosemide, then you might want to consider switching this patient to a more potent loop diuretic, that is what? Tosemide. Okay? And we know that uh, uh, tosemide is twice as potent as furosemide. If you have 20 milligrams of tosemide, it's equivalent to 40 milligrams of what? Of furosemide. You have to know these details because when you're on the ward round, you're the one supposed to educate the team there. That if the patient has been on 80 milligrams of furosemide every day, that means we need to give them 40 milligrams of tosemide. Are you seeing that? You need to know. You should be able to do that math. You can also add a thiazide diuretic. I think it should have been thiazide-like diuretic, okay, like metolazone. Thiazide-like diuretics have cardiovascular benefits, okay, lower risk of cardiovascular complications as compared to thiazide diuretics. Okay, there are other drugs like hydralazine, isosobide nitrate, and these ones reduce blood pressure. But we tend to use them a lot in patients who we have used all the GDMT, the guideline directed medical therapy, but are still having symptoms. We can give them hydralazine and what? Isosobide nitrate. We monitor blood pressure because the patient will have their blood pressure reduced. Patients who have a fast heart rate, their heart rate is more than 70. Number one, heart rate more than 70, heart rate, and their rhythm is sinus, they're in sinus rhythm, they have no arrhythmia, okay? And they're on a beta blocker, but you cannot increase the dose of beta blocker because the beta blocker, when you increase the dose, they're going to decompensate. These patients are going to give them ivabradine on top of the beta blocker. Okay, and basically patients who are above 75, you're going to give them 2.5 milligrams. You're seeing the dose there. So the evidence for this is gotten from the shift trial. If you have your internet somewhere there, you can actually Google and look at the shift trial later on. It talks about which patients uh, can be given ivabradine. Okay, this is still ivabradine continuing. We monitor for heart rate. Remember, the patient must not be having any arrhythmia. They must not be having atrial fibrillation. Okay? If they have atrial fibrillation, we will give them digoxin. We will not give them ivabradine. Okay, so these two, digoxin and ivabradine, will do the same thing in reducing heart rate. But the difference is one will help in atrial fibrillation, one will not be used in atrial fibrillation. This one, heart failure with sinus rhythm. Digoxin, heart failure with atrial fibrillation. The other drug that can reduce the number of times the patient comes to the hospital is vericiguat. This is given to patients who are already on the guideline-directed medical therapy, all the four drugs, but they're still having signs and symptoms of heart failure. But this drug is expensive. This is the Victoria trial. Okay, if you go onto your internet, there's a trial called the Victoria trial. You read about it. It talks about vaveristic and its role in heart failure. So basically, what you need to remember is this acronym: I need help. When do you need to escalate care? When you find yourself using inotropes, okay, inotropes, dobutamine, norepinephrine, dopamine. When you find yourself using that for your heart failure patient, you need to send your patient to Uganda Heart Institute, a specialist hospital. Okay, if you're in a general hospital, that's the time to consider sending them to us. If your patient is having end organ damage, they're having kidney derangement, they're having cardiac cirrhosis, these are patients you need to be sending to specialist hospitals. If the ejection fraction is less than 35, if you find yourself having to shock or cardiovert patients, okay, they're having arrhythmias, and then you see that their hemodynamic parameters are dropping down so much, then you need to be sending them to a facility like Uganda Heart Institute, where they can be managed by experts. If they're having more than one, if they have been to the hospital more than once, that patient needs to be sent to specialist hospital. Okay, if they are already on guideline directed medical therapy and you're seeing no improvement, or they are now starting to seem like they're stagnating, you need to forward them to us. Low blood pressure, okay, their heart rate is very fast. Tachycardia that you cannot explain. Maybe they have other underlying secondary causes of this tachycardias that we need to investigate and deal with at a specialist hospital. Okay, but that is basically for you to recommend to the medical team, or if in case there's an MO on the team, that is the time for you to look for a consultant or a specialist in cardiology. Now, I want to conclude with this acute decompensated heart failure. This one is a medical emergency or a cardiology emergency. Patients must be sent to the hospital for immediate care. Okay, ADHF is defined as a sudden worsening of heart failure symptoms. The patient has been okay, but suddenly difficulty breathing, they are wheezing, they are having crackles, they are having exertional dyspnea, their limbs are swelling. Okay, usually caused by cardiogenic or pulmonary edema with rapid fluid accumulation in the lungs. Okay, which will cause them that difficulty in breathing. These patients can end up in ADHF or what we call acute heart failure. You find some people calling ADHF acute heart failure. Okay. Or if you find someone saying, my patient is in heart failure, or my patient is in acute decompensated heart failure, or my patient is in acute heart failure, they are referring to the same thing. Okay. This problem can be precipitated by infection, by hypertensive crisis, okay, atrial obstruction like in MI, or bundle branch blockade, or mitral regurgitation that is acute fluid overload, non-adherence to medication. Even some drugs can actually induce heart failure or acute decompensated heart failure, like beta blockers. They can cause ADHF. If you give the patient a wrong dose of bisoprolol, a very big dose, okay, they can tolerate only 2.5, you're giving them 10 at once. They will end up with ADHF. Then you have to admit them. Okay, and these patients who I've told you they come with the acute symptoms of what? Of heart failure. The ones we talked about initially, those symptoms start manifesting. Now, important in heart failure is what we call cardiac index. Cardiac index is basically cardiac output divided by body surface area. What is cardiac output? Cardiac output is stroke volume multiplied by by the number of by the heart rate. Okay, the stroke volume multiplied by the heart rate gives you cardiac output. But now that cardiac output divided by body surface area gives you what we call cardiac index. Now, cardiac index is a measure of perfusion. Basically, how much blood is reaching the square meter every minute. That's the meaning of cardiac index. It is better. It's a better parameter of gauging perfusion than cardiac output. Okay, of all this blood leaving the heart, how much is reaching a square meter of your body? Okay, so another important term is what we call pulmonary capillary wedge pressure. Okay, and it is used to estimate left ventricular end diastolic pressures. The normal PCWP, okay, is 4 to 12 millimeters of mercury. However, it gets elevated in patients who have severe left ventricular failure or with patients who have severe mitral stenosis. Okay, it will go up. So basically that means the pressures in the pulmonary capillaries are high. And the result of that is your patient will have congestion in the lungs. Okay, so they'll have congestion in the lungs. Now, this table is very important. This table is very important because heart failure patients, patients who have ADHF, they can either be warm, they will be warm, they can you use words like warm, dry, wet, cold, you know what? Describe. Okay? A patient who is warm basically has good perfusion. Okay? And the cardiac index is more than 2.2. We talked about cardiac index being cardiac output divided by as you can see in what? In column 3. So a patient who is warm is what? Has a cardiac index of 2.2 and they're having good perfusion. Patient who is dry is having a pulmonary capillary wedge pressure. This is not the normal one. But for heart failure patients, this one will make them dry. Okay, something here. However, when they go above 18, they'll become wet. Okay, so if your patient is warm and dry, that's a patient who can go home. Normally, the goal of therapy in acute decompensated heart failure is to take the patient out of decompensation and make them what? Warm and dry. They come in with fluid overload and all that. Then they have good perfusion at the end of treatment. Then they must be dry. Their chest, when you listen to their chest, you won't hear crackles. Okay, that's a patient who can go home on what? On your GDMT. Are you seeing that? There's a patient who is warm and wet. This patient is having good perfusion, but they are wet because what? The PCWP, pulmonary capillary wedge pressure, is high. Basically, there is fluid in the lungs. When you hear the chest, you're going to hear crackles, and this patient will have difficulty in breathing. There's one who is cold and dry. This patient is cold because they're not perfusing, where cardiac output is low, therefore cardiac index is low. Okay, they are dry. Why? Because PCWP is here, 15 to 8, is not more than 18. This patient is also can be another one can be cold and wet. This patient is cold because they're hypoperfusing. Okay, and they are wet because of the high PCWP. So this table is important. Even to one MO, actually, this is very important to them. To a physician, this table is also very important to them. Even to a pharmacist, it's very important. Why? Because it helps you know that your treatment has worked for in ADHF patients. Okay? In ADHF, what's the goal of treatment in ADHF? The goal of treatment is improve symptoms. The patient has come in with dyspnea, we take away that. They stop having dyspnea. The patient came in with congestion, they're hearing crackles in their chest. And when you auscultate it, now they don't have. Basically, they're not congested. Okay? Their urine output is now good. They came in with poor urine output because of poor cardiac function. Now they're better. They're urinating better. Okay? You're restoring normal oxygen levels. SpO2 is no longer 85. It's no longer 80. Now we are 92, 93. We are doing well. Okay? Optimize volume status. Your patient is no longer having a fluid overload like initially. Okay? They came in swollen like a balloon. Now you have drained them and they are dry. When you press on their leg, you don't see ditches. Basically, you can see all that. Minimize side effects of drugs. Optimize chronic oral therapy. That is the GDMT we're talking about. Identify and address precipitating factors. Okay, you should find out why your patient got decompensation. There's always a reason. It can be infection. The commonest cause of decompensation in our setting is non-adherence to GDMT. Patients are not taking their medicines. Why? Because of very many reasons. Like what? Side effects, number one. Number two, financial constraints. These drugs are very expensive. So they will take for 1 week and stop. And then they will come back to the hospital the following week. And they'll keep coming back to because of non-adherence or poor adherence. Okay? So you need to sort that. If it is a problem of depression, you need to sort that. Some of them are depressed, they're tired of taking these meds. They've been on these meds for 10 years. Okay? They need someone to counsel them. And that is your work as a pharmacist. Okay? Everything I've been discussing here concerning management is very important knowledge for a pharmacist because you need to know these drugs in and out and see how to help the patient. Minimize side effects of drugs. Identify patients who might benefit from, perfusion therapy. Okay, patients identify patients who might benefit from device therapy, like pacemakers. Patients who have abnormal heart rhythms might some of them might need like bradycardias and might need pacemakers. Identify risk of thromboembolism. Who is at risk of thromboembolism? Like a heart, like a atrial fibrillation is a risk factor. They need anticoagulation. Educate patients concerning their medicines. This is work that has to be done. This is a patient who is on chronic medication for 10 years. They need a pharmacist next to them to teach them what's going on. Why am I on these drugs for 10 years? Am I going to get well? When am I going to stop them? What side effects do I expect? What do I do when I see my limbs are swelling? Okay? So these are very important things for you. Okay? In conclusion, you're going to see when the patient is warm and dry, warm means they're perfusing well. Dry means they're not congested. So you optimize oral therapy. GDMT, guideline directed. This is the time to discharge this patient. The patient is warm, they're perfusing well, but they are wet. That means they are having good perfusion, but they have fluid overload in the lungs, in the extremities, they are swollen, they have edema. Give them diuretics. You can give them diuretics. Then, if they're having fluid in the lungs, you can give them vasodilators like what? Etoposide dinitrate, which can reduce preload. Okay? Read about what preload is, read about what afterload is. In a cardiac setting, you need to know those words. What preload is and afterload. I won't go into that now. The patient who has cold extremities, they are cold and they are dry. They are cold because they're not perfusing well. Okay? This is the patient, and then they're also dry. They're dry, they're not congested. Okay? So these are patients who might need fluids, particularly if their PCWP is less than 15. If it is less than 15, this patient is what? Is not congested as such. Okay, so they are having hypo, low levels of what? Of volume. So you give them fluids, okay, to raise the PCWP to that range, 15 to 18. PCWP greater than 15, this patient is probably congested. Okay, they might not be necessarily congested. Greater than 15, but not more than 18. Okay, but they have a map of less than 50. A map of less than 50, this patient needs the vitamin. You need to help the heart pump. The vitamin is an inotrope. You need to help that heart pump better. PCWP greater than 15 and a map of 50 and above. And if they need an inotrope, you also initiate them. For example, if they are septic, if they are going to sepsis, you might need to initiate an inotrope for them, despite them having a map of 50 and above, or PCWP above 15. Okay. Then you're going to receive some patients who are cold and wet. A patient who is cold and wet is cold because he's having poor perfusion and is wet because it's congested. So that they tend to be volume overloaded, and the volume might be causing the heart not to pump well. So diuretics are very helpful for this patient. Okay, and if the MAP falls below 50, you need to do what? You need to give them an inotrope, the vitamin. Okay, I'm saying MAP, but I'm hoping you know what MAP is. MAP is measuring arterial pressure. Okay, the calculation is very clear. Systolic blood pressure plus 2 times diastolic blood pressure divided by 3 gives you MAP. And we always target a MAP of 65 and above. MAP of 65 and above. When MAP is below 50, okay, actually for us, when you're dropping below 60, we start thinking of inotropes. Okay, or if you need volume, you can give a patient volume and then you see fluids and you see if they will improve. If they're not improving, then probably the problem is pump failure or the heart is failing, cardiogenic shock. Okay, so MAP, the target is to keep your patient above 65. Okay, um, if MAP is more than 50, there's a compelling indication for inotropes. They're still like in sepsis, we will give this patient. IV inotropes. Um, if the MAP is more than 50 or 50 and above, and there is no compelling indication for inotropes, you can use vasodilators for this patient. Okay, vasodilators to like isozabide dinitrate if they are having congestion can be very helpful for this patient. So monitoring parameters for a patient in ADHF, blood pressure, heart rate, daily body weight, renal function is very key. Okay, daily body weight, my friends. Every day you must weigh this patient. Why? Because they're fluid overloaded. They came in with more volume. Therefore, that volume has weight. How do we know that furosemide is working? If they are reducing their weight. Okay, on a daily you check their weight until the day when the weight is constant and you're seeing they are dry. That's when you know you have achieved success with your furosemide. Do renal function because you're giving drugs that make the patient to urinate. These drugs make them to urinate, so they must be urinating. If they're not urinating, there's a problem. We also said some patients need volume replacement. Now you're giving them volume, you know they're not peeing. Okay, for any nurses on the call, you need to know this. Daily weight is very important for heart failure patients. Okay, blood pressures all the time. At Heart Institute, they're on a monitor all the time. We can see their blood pressure, we can see their heart rate, we can see their SpO2. Okay, we can see any other parameter like the ECG and all that. Renal function is very important for this patient. Urine output, again, nurses, urine output is very important for this patient. You want to monitor how much fluid has entered this patient and how much fluid is coming out, and you do a fluid balance. Okay, are they retaining more fluid or they're losing too much fluid? We need to know that to see if our diuretics are working and to see if our prognosis is good. Electrolytes, this patient is peeing a lot. You're giving them diuretics. These diuretics lose sodium, they lose electrolytes, they lose potassium. You need to know if they're okay. If these electrolytes keep dropping and they become hypo everywhere, or if they become hyper, they will go into what? Arrhythmia, get arrhythmias and they will die of arrhythmias. Okay, or you will not get out of decompensation. Okay, so when you're discharging a patient with ADHF, treat the causing. If it is the infection causing decompensation, treat the infection. Pneumonia is a cause. Okay, patients should be dry, warm and dry when you're sending them home. Okay, and when they're warm and dry, you see them walking around. Okay, a patient who is not done and the patient must be stable on their oral meds for at least 24 hours. Okay, patient and family education is very important. A cardiac patient must be observed all the time by their caregiver. Okay, they should be observed all the time because they can go to the bathroom and not come out. Okay, so they have to be observed by their caregiver. The medicines, you must teach the caregivers, you must teach the patient how to take the medicines. Because if they take the medicines wrongly, they're going to end up in decompensation again. And the medicines can kill the patient if you give them wrongly. The patient must have their documents well kept. They must stop smoking. Smoking is a big risk factor for cardiovascular diseases, all forms of smoking. Okay. There must be review date set for this patient. They must come to the hospital for review. Optical guideline directed medical therapy. Okay, we say titrate the doses to the target, to the target, to the targeted doses as seen to be beneficial in clinical trials. Then talk about post-discharge management. How are they going to live at home? Where are they going to access any minor care that they might need? Okay, if they're going home on IVs, where can they get the care from? If they need refill for some medication, where can they get it from? Okay, is there some cardiologist where they come from that they can keep visiting? These are things we talk about with the patient. Now we go to our task as we conclude. Okay, we said our patient is 70-year-old and is KD. He comes in with dyspnea. Orthopnea is a fatigability, bilateral lower limb edema for 3 days. He has been on heart failure medication for 3 years. However, ever since his son, who works with USAID, lost his job a month ago, his adherence has been poor. Okay, cardiac echo shows ejection fraction of 40. with systolic dysfunction. Cardiologist tells you this guy, KD, has significant bilateral fine crackles. Okay? And these BPs look like that 100 by 70, a heart rate of 105, SpO2 of 85. Okay? What are the goals of therapy for this patient? First of all, what are the abnormal findings in this patient? Now, this is the time for people to unmute and talk to me. I will not choose. I will not. I'll just. I just expect you guys to be able to unmute and talk. Madam Moderator, are we still on the call or I'm talking to myself?
We are still on the.
Yes, so
Yes, so
can someone tell us?
can someone tell us?
I hear feedback. Eh? That means if I unmute you,
The feedback.
you can talk.
Thank you, Doctor, for the presentation. It has been from the case that you have presented and I'm seeing here, I see this patient already has reduced ejection fraction. Together, if I also check on the heart rate, it is also an increased heart rate. Thank you.
Okay, very good. Your name?
Kenneth Mathiko, an intern pharmacist at Arwar General Referral Hospital.
Okay, well done. That's very good. Eh? Any other abnormal findings?
Literally every finding is wrong. Like you look at the carcass, that means there is pleural effusion. Look at the BP, it's low. The heart rate is also high. Then the SpO2, that means it's desaturating right now. So then also the ejection fraction is also low. That means he's in heart failure with reduced ejection fraction. Yeah, thank you.
Okay, that's very nice. You didn't tell us who you are.
My name is Nalia Caroline, and I'm an intern pharmacist at Sorority General Referral.
Okay, well done. Any other issue that is abnormal is that patient that's presenting complaints like dyspnea, and edema for 3 days. That is also abnormal. Eh? So, what are the goals of therapy? I just need one from 4 people, like one from each person. Eh? Remember, goals of therapy must be specific, they must be time bound, they must be measurable or objectively quantifiable. Okay? So, when you're stating them, you should always be able, remember those 3 things. They're measurable, they're specific, they're time bound. Okay? So, tell us, you have seen the abnormal findings. What are the goals of therapy for this person? Talk about the SpO2. Talk about the heart rate. Talk about the crackles. Talk about the edema. All these can be measurable, or they can be objectively examined, okay, by a cardiologist or by you yourself. You can do heart rate, you can check SpO2, you can check, respiratory rates. You can even observe the patient. So, how would you state your goals of therapy? Pharmacists are not shy people. Eh? You should be able to talk to express yourself in public platforms. we there?
Uh, thank you, doctor. This is the Bossa from Barrier Referral Hospital.
Yes,
I
what we
think
are.
if I'm to mention one goal of therapy,
Mm.
it would be to lower the heart rate to 70 or below beats per minute.
Okay, that's very good.
Mm.
Another one?
Thank you, Doctor. Once again, Kenneth Masiko from Original Referral Hospital.
Mm.
Another goal of therapy is would be to raise the SpO2 to above, at least above 95%. Thank you.
Okay, that's good. 95 might be very ambitious, but 92 is okay. That's very good. Masiko, let me not let me get other people now. Because some people might be sending you as their representative. I want to hear their voices also. Can I get another person who has not said anything? Most preferably a lady.
Good evening, Doctor. This is Kenneth Kajumuri, an intern pharmacist at Anaka General Hospital. My next goal of therapy would be to increase the ejection fraction that is above 40%.
Okay, that is a good one. Um, However, it is not very common for us to be able to increase it in a short time. Okay, what you're saying is correct, but that will happen over some time. Okay, by discharge, you might not be able to achieve that. The other thing I notice all of us are forgetting is stating how long. Okay, by the time the patient is discharged, we expect them to be in hospital for about a week, less than a week, 5 days, 3 days, they go home. Okay, so all whatever you're talking about must be in 3, 4 days. 3, 4, 5 days, your patient must be able to look like what you're telling us. Someone talked of heart rate, someone talked about we're talking about SpO2. All these by 3, 4, 5 days should have resolved if you're a serious team managing these patients. Okay, but ejection fraction can reduce. I mean, can increase in some patients, but it might not happen immediately. And also, it will happen in only a few patients. Not all of them will have ejection fraction improving. We should just know that, okay? Let me have someone else say something. Talk about the fine crackles. Talk about these things that look obvious, but you should be able to articulate them. Should be able to articulate them. Talk about the fluid overload, the edema. To articulate them. Talk about the fluid overload, the edema.
I I would say the fourth goal of therapy as being lowering the patient's edema, like addressing the edema.
Okay. So
Okay.
by by the end of 3 days or 4 days, the patient must be dry. Okay, must be dry, and dry means that they are not fluid overloaded. We should not be having crackles in the lungs. We should not be having edema in the extremities, or even any form of ascites. Any other? How many others? There are like four already. The rest we can add on. No? Let's go to the
Yes.
recommended. Yes.
When you look at this patient's age,
Mm.
corresponding to the BP, they found was about 100/70. So I think we need also to improve on the blood pressure above 120. That is a systolic, and the diastolic probably above 80.
Okay, that's a very good one. We can improve this patient's blood pressure. However, that's like a secondary goal. Now, my big question will be how are we going to increase this patient's blood pressure? Now, that is a pharmaceutical care plan. How do we expect to increase this patient's blood pressure? In a pharmaceutical care plan, we have,
Doctor, sorry,
yes, please.
we cannot hear. Like the voice is shaky.
Okay. Um, can you hear me now? So I was saying that when you go to a pharmaceutical care plan, we normally have a indication for the drug, we have the medication or the treatment, pharmacotherapy, then we have monitoring parameters. Okay, uh, what are we going to? How are we going to design a pharmaceutical care plan? Tell me about what drugs you're going to use and their
Okay.
indication.
Um, can you hear me now?
Yeah.
They're in.
Can I have someone telling us something?
Dr. Silas, I think Dr. Catherine has some problems with the network, because for us, me here personally, I'm listening to you and I'm getting you very well.
Okay.
Excuse me, Dr. Silas.
Yes, Daniel.
Yes. About the blood pressure.
Mhm.
Is the blood pressure low? Because me, I see it's within the normal range. The systolic being 100, still within the normal range of 100 to 120. Then the diastolic is 70, which is still in the normal range of 60 to 80. But I don't know whether I'm wrong, because I see BP has been questioned as being low.
Well, that blood pressure is actually normal. Okay, that blood pressure is normal. Um, what's important in a patient with decompensation like ours is not necessarily the blood pressure, but what is important is if your patient is warm and dry. You're seeing that because you want to make sure you have good perfusion and you want to make sure you're not congested. Okay, so the issue is not really to increase blood pressure, and I like I said, our goal, the primary goal, is not to necessarily increase blood pressure unless we see ourselves having a map less than 65. If we calculate the map of this patient, what's the map of this patient? Who has done the map? Is it less than 65? So what Daniel is asking is very important because the only way you're going to know your patient is hypoperfusing, is not having enough perfusion, is when you have a map less than 65. Okay? When you calculate the map of this patient, systolic blood pressure is 100, diastolic is 70. So systolic over 100 plus 2 times diastolic, which is 140. So 100 plus 140 divided by 3, what do you get? You get 80. Does everyone get 80?
Yes.
Okay? Systolic over 100 plus 2 times diastolic. Everything divided by 3, you get 80, right? And that is the map of this patient. It is above 65. Okay? So this patient's blood pressure is not really low. Are you seeing that? It's not really low, and the map of 80 is good, particularly if your patient is if what is in decompensation. So what Daniel is asking is very important. Okay, so increasing BP for this patient is not a primary goal. Okay, it's not a primary goal, but the BPs will increase by themselves once we are out of what? Decompensation. Okay, once we drain this patient of that extra fluid we are seeing, once we reduce the heart rate of this patient, okay, well, once we achieve a reduction in heart rate, we achieve a reduction in congestion, we are going to have BPs rising by themselves. Okay, so let's look at the care plan. What are the drugs you're going to use for managing this patient? Who can tell us what's the first drug you want to think of?
give it a try, doctor?
Pardon?
Can I give it a try?
Oh, yes, please do.
Yes. Now, because we have not been uh, in the history, I've not seen whether this patient is naive on the drugs for hypertension or aplasia or anything. Hoping this patient is naive on the medication. So the first indication would be heart failure drugs, and ejection fraction is 40, which is the upper limit to be considered as heart failure to reduce ejection fraction. So as you discussed earlier, we would have the popular drugs, that is our honey, starting at the lowest dose possible, which is 50 mg. And our monitoring parameter there will be the BP, the kidney function, electrolytes. And the target would be to increase maybe every 2 weeks, 1 to 2 weeks, following for the patient to achieve the 200. Then the second one would be the mineralocorticoid antagonist, that is steroidal, Tylenol or maybe spironolactone, starting also at the lowest tolerable dose and increasing slowly, as we also monitor electrolytes to prevent hyperkalemia. I think there would also be a baseline need to take the electrolytes before we can start the protocol. Then, of course, the other two, that is the SGLT2 inhibitors and beta blocker. One of the three, Copedilo, and the so-called starting at the lowest tolerable dose and titrating accordingly. But of course, the beta blockers will limit rate and the blood pressure. Then SGL2, we have to monitor oxygen levels, electrolyte levels, and the blood pressure. Again, because this patient is decompensated, additionally, we may need diuresis. So we can add maybe
So Daniel, Daniel,
yes,
you can hear me?
yes, I can.
So now that point of decompensation you've started with is what is the most important thing that's happening to this patient. You've talked about decompensation, okay? When a patient walks into your facility and they're in acute decompensated heart failure, the most important thing for them in terms of management is diuresis. You're getting it, eh? Everything else can wait. Everything else can wait. Your patient is fluid overloaded. They have come with edema. They have come with crackles in their lungs, okay, in their chest. They have come with heart rates above 100, more than 90. You're seeing that. Basically telling you they are congested. The heart is not able to contract and relax well because it is full of what? Volume. So what is it? Your patient is fluid overload. Your patient is basically wet. And what did we say? If we go back to our chart, a patient who is most likely your patient has come where the map is good, right? Our map is more than 50. Um, Let me look for okay. Our map is not bad. But what are we saying? The patient is hypoperfusing and uh, they are cold and wet, hypoperfusing. They need diuretics. Okay. Another one is well, let me find somewhere else. Hypervolemia. They are warm and wet. Are you seeing where we are, Daniel? Our patient has a good map, which means they're probably warm. They are wet. Are you seeing? And if they are wet, what do we do? It's diuretics, plus or minus vasodilators. Your GDMT doesn't come in ADHF. Everyone must listen to this and note this. A patient who is in ADHF, we don't initiate GDMT. We first manage the decompensation. And what do we use? Diuretics. That's why if you look at this table of ours, our patient probably falls here. Their map is good, above 65, so probably they are warm. Then they are wet because they have crackles, they have edema, so they need a diuretic. They are volume overloaded. So what I expected to hear from you, Daniel, is this patient needs a diuretic ASAP. Okay? After diuresing this patient of mine very well, eh? And I'm seeing that urine output is good, daily weight is reducing, eh? And I'm now coming close to warm and dry. Are you seeing warm and dry? The goal I expect from you is to take this patient from warm and wet. Our patient is warm and wet. Warm, they're perfusing well. Map of 85, 80. They are wet, crackles, edema. They are warm and wet. Now we want to make them warm and dry. When they are warm and dry, that's when we'll give them what you're talking about. But before that, if you give them all those drugs you're talking about, that BP you're seeing will drop. You're going to kill that patient. They will die. You're getting it? When we are warm and dry, then we shall start introducing one by one those drugs you've been listing. One by one. Are we together, guys? So what I expect to hear is the patient will be on furosemide, okay? Maybe 40 milligrams BD, maybe 40, an infusion, but furosemide, what I want to hear, okay? Why? Because the patient has edema. The patient has crackles in their chest. Actually, edema is the indication for furosemide. They are wet. They have edema. Parameters. What do we monitor for a patient having edema? And they're on furosemide.
Monitor the patient weight, and you can also monitor the electrolytes.
Okay, so who is this who is talking?
This is Marieko Emmanuel Arion from Masaka Regional Referral Hospital.
Okay, very good. Okay, so Daniel, I hope you got Daniel. I hope Daniel got me right.
Yes.
But also, okay, that is very important. So we monitor the patient's daily weight. We say daily weight. We need to know the patient's daily weight. Are we reducing? Are we losing the water? Okay, are we? BPs are very important. We are losing volume. We are draining the patient of fluid. But basically, the blood volume is reducing. So we need to monitor BP to make sure we don't go below what a map of 8 or what of 65. What else do we monitor for?
We also monitor the urine output of the patient.
Urine output of
Urine
the
output of the
patient.
patient.
What's the target urine output of this? What do we want? What do we expect to see? What's a normal urine output? Pharmacists need to know this, my friend. You need to know if your furosemide is working. And if you don't know your urine output, then you can't monitor. You should be able to know. You are going to measure your patient's urine output. You're going to pee in a container and you're going to measure that urine and see how much has been passed. Yes, the nurse can do that, but you need to be aware of what's going on. You need to know how much urine they are passing every day. And how do you know? What is the normal urine output? Who knows?
0.5 mils per kg per hour.
Okay, 0.5 mils per kg per, that's the minimum. Okay, we don't expect it to go below that. If it is 1 mil per kg per hour, that's good, but it shouldn't go below 0.5 mils per kg per hour. Anything else to monitor? We talked about electrolytes, talked about blood pressure. Someone talk about okay, there's something else I want to hear. Our patient has crackles. What does that tell you? Our patient has crackles. Those crackles means the patient has pulmonary edema, isn't it? And pulmonary edema is coming because of what? Because most likely you're having pulmonary capillary wedge pressure that is elevated. How do we solve that problem? Okay, we need to reduce the patient's preload. And which drugs do that? We talked about what? Exacerbate dinitrate, isn't it? This patient is having crackles in there. You can listen to it and you hear crackles. So they need exacerbate dinitrate, okay? Because they're having pulmonary edema. We are not able to, we may not necessarily on the bedside or in a hospital, we not, or in some hospital, you may not be able to measure the PCWP, but you're going to know that your patient has crackles. The cardiologist will check the patient, will examine the patient, or your physician, or the MO will tell you, I can hear crackles bilaterally. My patient is in heart failure, difficulty in breathing, SpO2 is low. What do you do? Exacerbate nitrate, reduce preload to relieve the pressures in the pulmonary vasculature. What do you mean for? Blood pressure. Because ISDN will reduce blood pressure of your patient. It will relieve the symptom of, difficulty in breathing and crackles and all that just, but it will reduce your blood pressure. Okay? So those are the two drugs that are expected. There's another one. What else do you give this patient? People who are observed, SpO2 is 85. What do? You just look at the patient with 85. You start this patient on oxygen. Okay? This patient should get oxygen. What's the target? Someone mentioned 90, 90. We said 92 is okay. Okay, 92, 93, 94. We're doing well. But right now we're at 85. This patient needs supplemental oxygen. Put them on mesoproms. Okay? That is what we do for this patient. Monitoring parameter SpO2. Are you seeing that? That's the care plan for this patient. Our patient is in ADHF. We keep that treatment until we are hearing no crackles, until we are starting to see that the patient's fluid overload is reducing, the edema is going away, until we are seeing the patient is breathing better, until the patient is able to walk around. They're able to walk around the bed. They're able to go to the chores by themselves. They're not complaining of easy fatigability anymore. Then you know you're out of decompensation. Then now you start introducing what Daniel was talking about, GDMT, the Fantastic Four. Okay? Because all along, what have we been doing? We have been relieving symptoms, symptom relief. Now, when they're out of decompensation, we start bringing what gives us prolonged life. Now we start prolonging the life of the patient with the four pillar drugs. We bring in one by one at the least possible dose. Now, you've discharged your patient. After 1 week, they are back. They've come for review, right? And they've come back for review. Oh, sorry. We have managed their patient. They haven't yet gone home. They haven't yet been discharged. Now we are planning to discharge them. We have achieved. Our patient is now warm and dry. Okay? Warm and dry. Everything is good. They're happy with you. They're telling you, however, they could thank you for doing a good job. But I think you're telling them, I think you need to go home now. What is your discharge plan? It is what we have just talked about. What Daniel talked about, the GDMT. But on top of that, what are you going to tell this patient? What are you going to do? What ladies and gentlemen? I want someone to tell me what was the cause of the conversation. Non-adherence caused by what?
I think financial constraint because of the loss of the job.
Okay, very important, ladies and gentlemen, very important. The reason why your patient came to the hospital. That is the actual reason. This patient would have been at home, but they came because someone lost a job and they to buy some of the meds. And what did we say about Sarcoplus?
It is
What did we say about those drugs?
it is costly to afford.
Cost, ladies and gentlemen. You're seeing that if you send your patient home on the same drugs he was on, chances are high he's going to come problem after a week. You get it? Now we know he can't afford the ANI, valsartan sacubitril. It's expensive. What do? We get for him an ACE inhibitor. Send the guy home on another pill. Get it? It may not necessarily be as good as ANI, the sarcoplas, but it will give us some benefit. Send the guy home on another pay, which he can afford. You guys know the prices of these drugs. Okay? The pharmacist must have that in mind all the time. The cost of your treatment. It can make your patient become underweight. And your goal is to make sure your patient is a DRN. See that? That's what we do on the ward, my friends. Now, discharge plan, make sure you're prescribing, we're talking about medicine plan of medicines, you're dealing with the cause of admission, dealing with the cause of decompensation for this patient. Okay, we want to send them home on the cheapest medicines possible. However, clinical trials. GDMT, but we're sending them on the cheapest options available. When you're sending them home, don't send them home on a Plerinon. Plerinon is more expensive than what? Spironolactone. Give them spironolactone. Don't send them on Sarcopas. Send them home on what? Enalapril. Even among the beta blockers, some are more expensive than others. I don't know how much metoprolol might be. It might be more costly than bisoprolol. I don't know. Okay, but you see, every class of drug, pick out the least expensive, the cheapest, because now we know the cause was what? Financial constraint. That's the discharge plan. Tell them how long they'll be on. Tell them about this is what we call discharge plan. Don't just give them the meds and talk about counseling or DRN. Talk about all these things. Finally, not finally, but second but not last but not least, KD returns after 2 weeks for review. He's coming back for review, and he meets your team. But now he has a tachycardia of 98. Okay, yet he can tolerate small doses of beta blockers. If you try to increase the support from 2.5 to 5, the guy gets what? He becomes weak. Eh? He starts telling you, I'm very tired. Hey, doctor, I'm very tired. The cardiologist is telling you, the ECG looks good. The guy is in sinus rhythm. But the problem is what? Tachycardia. He has a tachycardia, he has a sinus tachycardia, he has a tachycardia. So what do you do? Can someone wasn't said anything? What do we do for this patient? You would have increased the dose of beta blocker, but when you try to increase it, this guy develops symptoms that are not nice. He's tired, he's decompensating. What do we do?
I think when a patient, when this is not tolerable, the best option would be ivabradine.
Good. What's your name?
This is Mwanga Umar, student.
Good. Okay, ivabradine. What are the conditions for starting ivabradine? The patient must have a heart rate more than 70. Okay, that's number one. Ejection fraction should be reduced. Our patient has an ejection fraction of 40. Number three, our patient must be in sinus rhythm. And this patient meets the criteria, ladies and gentlemen, ivabradine. Yeah? It doesn't prolong the life of the patient, but it reduces the symptoms. Ivabradine. I'm very happy to hear that from her. Okay? So what is the target heart rate for this patient? From 98 to what?
Should be between 50 to 60, probably.
Okay, that's also good. Okay, now we have answered number four. Now you're there, you guys are doing suddenly the patient goes into atrial fibrillation. Cardiologist looks at the ECG and is like, oh, we have an AFib. We don't see P waves on the ECG. Yeah, we have atrial fibrillation. But the patient is hemodynamically stable, meaning good, heart rate is good, map is good. Okay, they are warm, but there's a problem with what? They're having AFib. Okay, patient has AFib, and maybe I can actually modify it. Okay, they're having fast rates. When I say normal heart rates, you might, but let me say that having fast tachycardia. Okay, AFib with fast rates. Okay, what do we do? And our patient does not want to be cardiovascular. When a patient gets atrial fibrillation, okay, atrial fibrillation, and acute atrial fibrillation, we can actually cardiovascular the patient. If it happens while you're seeing it and it has just started, it has never happened before, it has just started, we can shock the patient. Okay, you cardiovascular, we call it direct current cardioversion. But it's a procedure that's uncomfortable. Some patients might decline. Okay, you see it in movies, patients who are being shocked with electricity. But this patient has refused that procedure. What hope do we have for our patient? Does someone know?
Give a beta blocker or non-diethyl
The patient is already in a beta blocker.
We give digoxin.
Who is that?
You can hear it stuff of Zambia Hospital.
Thank you very much. Thank you very much for that. The Digoxin is a go-to drug. I feel like I've successfully told you people. Okay? The patient gets the digoxin for atrial fibrillation. We said it's the probably the most prominent indication for the digoxin atrial fibrillation. We said when a patient has fast heart rates and they are in sinus rhythm and they meet the criteria of FREF and they all that we do evaporate sinus rhythm. But if they have an AFib, we give them digoxin because they in atrial fibrillation. Okay. Now you've recommended digoxin. Before we give digoxin, what are the monitoring parameters? What are the baseline labs we have to do? I want to hear. Can someone tell us?
Potassium levels.
Why? Why? Where do we check for potassium levels? Because in hypokalemia, there's a huge risk. Actually, hypokalemic patients receiving digoxin are prone to getting digoxin toxicity. Digoxin and potassium compete for the same binding site. So once the potassium levels are low, digoxin will be celebrating, they will run by would have bound. Then the patient will start manifesting with digoxin toxicity, bradycardia. They go into bradycardia. From bradycardia, they can even go into AV block. Okay, then they go into a cardiac arrest and they die. So you have to make sure your potassium is 5, which is a lower limit. That's number one. Number two, digoxin. What else do you monitor for?
Owen is raising his hand. Owen.
Yes.
Yes.
Owen,
You can also monitor for
Yes.
magnesium.
yes. Thank you very much. There's a
Yes.
lady who said monitor magnesium. Correct.
Using monitoring magnesium.
What's it?
Still ester.
Okay. Thank you very much for that. Then there's another one. What else? We monitor heart rate, magnesium, potassium. There's something else we monitor for. Renal function. Okay. Digoxin is renally excreted. Okay.
Yes.
Undergoes renal excretion, so you need to monitor for renal function. If the renal function is poor, when you look at Medscape, I think you will see somewhere where it will tell you how to adjust the dose. Okay, in a settings where they have machines that do TDM, they actually do digoxin serum levels. But in our setting, it's a bit complicated. Maybe in our new home of Uganda Heart Institute in Naguru, which is being constructed, we might have that. Okay, but for now we don't. So we would have checked for serum levels of digoxin. If patient has, if this guy goes into digoxin toxicity, what do we give them?
Yes, we give Joxin immune antibodies, the ovin.
Okay, okay. Who is that? Who is that is giving a good answer?
Owen.
That is Owen again. Okay, that is a very correct answer. Now your patient is
Yes.
atrial fibrillation. Your patient went into atrial fibrillation. You've given them digoxin. What else is missing? There's one more thing missing on this patient's treatment. Remember Chadsworth score. Patients who have atrial fibrillation, we have to do Chadsworth score for them. You read about Chadsworth score. Okay? A score of 2 and above qualifies a patient for anticoagulation. This patient needs an anticoagulant. Are we together? They need an anticoagulant. Why? Because we have to prevent the risk of blood from clotting. This patient, atrial fibrillation is a risk factor for blood clots, a risk factor for stroke. Okay, so we need to give this patient anticoagulation. Okay, a apixaban dose, you start the patient on maybe 5 BD, 5 milligrams BD, or you can give them offering. From offering, monitor INR. Okay, and then for apixaban, you're going to monitor for any signs of abnormal bleeding. Rivaroxaban, you also you start the patient from I think 15, but you need to monitor these patients for signs of abnormal bleed, but also do renal function because apixaban and rivaroxaban are renally dosed. Okay, we do renal dosing for them. Actually, the dose is 20 for rivaroxaban, but if you suddenly with EGFR less than 50, rivaroxaban is given at 15 milligrams, not 20. What D? For apixaban, is a criteria. If the patient has a weight less than 60 and the patient has a age above 80 and serum creatinine above 1.5, 2 out of 3 of those criteria, we are going to start apixaban at 2.5 and not 5. But if they don't have any of those, or if they only have one of those, we will start it at 5. Allow me to stop my presentation there. I thank you for tolerating my long presentation, but I hope I've been helpful to you. Thank you very much.
Thank you, Dr. Silas. Does anyone have any questions? Like someone is raising a hand. You can please speak on.
Thank you,
Yes, doctor.
Kathy.
Doctor, I
Doctor.
was inquiring about the. Sorry, let me first speak. Doctor, I was inquiring about the point of diuresis. When we're using tosemide, furosemide, or butenamide, what do we consider? What ratios do we consider to transfer from IV to oral or from oral to IV on admission? Like, is there a ratio we consider? Because I was reading something, but it was not being very clear.
Okay, so what you need to know is always read about the equivalent dose for IVs and orals for these drugs. Yeah, for instance, Oral furosemide, I think, is about, when you compare it with IV, about 60%. Okay, oral furosemide is about 60% bioavailable compared to IV percent, which is 100%. So if you take a tablet of 40 milligrams of oral furosemide, you should know that 60% is what is reaching the bloodstream. Okay, as opposed to if you're taking IV furosemide of 40 milligrams, 100% reaching the bloodstream. So those differences must put into consideration. That's for furosemide. Okay, so basically that means that if a patient is on oral furosemide, the equivalent dose when it comes to IV is almost double. Okay, yeah, I'm not familiar with tosemide. That has no IV formulation, unless I'm mistaken. But I think we only have orals for tosemide. Okay, and if you're transitioning from furosemide to tosemide, then you should look at the equivalent dose. Like I mentioned, furosemide and tosemide. Tosemide is 2 times more potent than furosemide. So that is what I can say about that. Any other question?
Yes, thank you. Doctor, I
Yes,
need to
thank you.
inquire.
Doctor, I need to inquire.
I'm inquiring, would, like, when you're making a choice between isosabide dinitrate and isosabide mononitrate, what do you consider? Like,
Number one, I would say your guidelines. Okay, the guidelines are clear about which one we use. The guidelines are clear. We're using ISDN. That's what we are relying on, because most of these drugs are going to ask, why are we choosing this over that? It's simply because trials have demonstrated benefit. And everything I've talked about, maybe I didn't tell us. The information I've talked about is in those references. If you can see the screen, that's the reference. Some of these findings, we can't conclusively say why some of these drugs are beneficial in what and all that, but all we know is that they have demonstrated benefit. For instance, I will tell you, now like uh, alogliptin, they're saying associated with heart failure. If you ask me why, I don't know, but the clinical trials showed that patients who are on alogliptin did not perform well in terms of heart failure benefit. Instead, they worsened. Actually, most of them died. Okay. Then, if you ask me why does SGLT2 inhibitors have mortality benefit, I honestly don't know why. But clinical trials have showed us that it is what has heart failure mortality benefit. You get it? So it's the same thing really here. That means that you need to acquaint yourself with these clinical trials and also with these guidelines. Please read these guidelines and make sense of them. Okay? Okay. Anyone else?
Let's have Barishava and then Posiano and then Kenneth in
Yeah,
that
thank
order.
you very much. Yeah, thank you very much for the question is about digoxin actually. In our patient was in, but like after he came in with atrial fibrillation and we opted for digoxin. How long do we hold this digoxin? Because digoxin also in our patients, in most cases, it is one of the things that lead it actually. People on digoxin have poor prognosis. I don't know. Do we hold it until the patient dies, or we have terminate the digoxin and maybe opt for other drugs? Thank you.
Okay. Thank you very much for that question, Andrew. So, digoxin has an it doesn't prolong the life of the patient, but it reduces signs and symptoms of heart failure. It can also be used for rate control for our patient who has atrial fibrillation. So, and the reason why we have gone for digoxin is because we are on a beta blocker but we are having AFib with fast rates despite being on a however, beta blocker can be used in population, but for them they have mortality benefit in heart failure, which means that the time when they can tolerate bigger doses, we shall step up the dose of the beta blocker and remove the digoxin. Are you saying that? So monitor your patient. The day when they're able to tolerate big doses of beta blockers, maybe after 2 months, maybe after 3 months, if blocker, that's when we go. Okay, digoxin also has problems. It has side effects, a very poor side effect profile. That's why people don't like it in health practice. Okay, narrow therapeutic window, very prone to digoxin toxicity. So you can keep the patient on it for a very short time. As long as you don't need it, you take it off. Okay, any other question?
Yes, doctor. Thank you very much. I have a quick one. Considering the choices of the beta blockers, particularly metoprolol, we know the succinate is the extended release and the tetracycline, the immediate release. Is there a particular reason why we should choose the extended release, or you would relate it to adherence, all the things you have said earlier?
Yeah, first of all, in the study again, they talked about succinate. They specified actually, so that means that's the one they tried. Um, that's one. But two, again, tartrate has benefit in other scenarios that is not succinate. I do not have an actual explanation as to why it is succinate. Honestly, I don't have. Still, again, I will tell you it's because that's what the guidelines are saying. Okay. Uh, the reason why the three BCN, bisoprolol, carvedilol, and are chosen, and why particularly succinate in metoprolol, I cannot. I can just say that because of the benefits seen in mortality, the mortality benefits seen for those. And then you find that other drugs have been tried and they have not showed mortality benefits in these patients. And again, we can't explain why. And that's why they're called cardioselect, because from somehow clinical trials, they're the ones that have showed benefit for these patients. Okay. I don't know if that answers your question really. Do I have any other question?
Thank you so much, Dr. Cyrus. Together with the team and other members we have here on our platform, or the ones who have attended the session, I would have brought in more questions, but it's a bit late. Doctor, if it is possible, you can share with us your numbers and contacts on how we can approach you. But we appreciate for your time and the knowledge you have shared with us. All of us have picked at least a leaf from whatever you have shared with us. Me, I would suggest that without wasting time, we stop the session and we have other interactions, maybe personally, either on email or WhatsApp. Otherwise, thank you so much for your time and what you have done for us, what you have shared with us. Back to the moderator.
Yeah. Thank you so much, Dr. Silas, for the presentation.
Thank you.
We can, like, maybe you would share the contact and then we share it later to people for further questions.
All right, you guys. I think you guys have my contact. There are a bunch of people who have my contact.
Thank you. All right, you guys have my contact. Go back to my contact.
Yeah. Thank you so much, sir.
All right.
For those who are in need of doctor's contact, as the association, we shall provide a link where you can get to through. Thank you so much, Dr. Silas, for a wonderful presentation and the insights you shared with us. We are really grateful.